Hello and welcome. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and welcome to our program, Surgical Pathology, Digital Slide Review, and Sign Out. Our program is part of the Digital Anatomic Pathology Academy, which is the joint venture with Path Presenter and with the Digital Pathology Association. So our case today comes from the realm of GYN pathology and is that of a perimenopausal woman who has recently undergone a surgical procedure for removal of an ovarian mass, which reportedly was diagnosed as endometrioid adenocarcinoma. However, postoperatively, she developed some additional symptoms and was transferred to our hospital, where further examination and additional biopsies were performed. The first sample that we received on this patient was a vaginal mass biopsy, which, as you can see here, is represented at low power and shows some intact squamous mucosa along the surface, and then areas of bluish discoloration in the deeper portions of the tissue. As we examined this, I could see that there was a great deal of crush artifact that somewhat distorted the tissue here, making me wonder if this was a neuroendocrine neoplasm or lymphoma or some other very fragile type of carcinoma. There was very little material here that was residual and staining, or that was recognizable with much in the way of nuclear morphology. However, the overall pattern of an apparently somewhat infiltrative lesion deep to the mucosa, to me was highly suspicious for a malignancy. However, I didn't have the benefit of having seen the other slides, nor even having the report available to me. So I was kind of stuck with trying to make out what these crushed cells could be. Here you see some that maybe up in a vessel or something of that sort, and a few small cells here, just very crushed. So they're obviously very fragile cells and not particularly staining well. So I initially thought, well, what will I do to evaluate this? Is this a neuroendocrine carcinoma? Is it a carcinoma? Are these inflammatory cells? I could do some immunoperoxidase stains. And in fact, those were performed, which showed no evidence of cytokeratin, no evidence of PAX8, and no evidence of neuroendocrine markers. So think about that for a second. And we'll go on to the third sample, which was an endocervical curettage sample. This sample also was quite cellular and showed a few areas of glandular type tissue. But then, as you can see here, we have a very high-grade malignant process with a few sheets of cells, prominent nucleoli, mitotic figures, karyorrhexis, and all of this underlying a relatively banal or benign surface cuboidal type of epithelium. There wasn't a lot of this, but it was clearly present in several of the fragments and associated with some necrosis, as you can see here as well. So then I'm thinking, well, okay, maybe this is an undifferentiated neoplasm. Maybe it's metastatic disease. Certainly this pattern could be anything as well, including lymphoma, melanoma, and so forth. Well, let's go on to the next sample, which was from the endometrium. And there we could see Again, areas of necrosis, but clearly some areas of glandular differentiation, as I've highlighted here in this bounding box, with good gland formation, fairly uniform nuclei, basally located, more of the notion of endometrial type carcinoma. Then looking around, we see there are areas where we have very pink material, which had a somewhat squamoid appearance, keratinizing. And there actually are quite a few of those, as well as some areas that look a little bit more like what we saw in the endocervical sample with a higher grade sheets of malignant type cells. So with this pattern, the picture began to come clearer to me as we realized that we had a low-grade endometrial carcinoma coupled with a diffuse high-grade sheet-like pattern of growth going on. Now, the other interesting features here, as I mentioned, were these areas of keratinization, which, as you can see here, are quite numerous, and they're in this little nested pattern and category, similar to what is often seen in keratin granulomata that can be present either in association with certain invasive tumors and on occasion even within the peritoneum, where they may mimic or masquerade as areas of metastatic neoplasm. And this, along with the very diffuse high-grade malignant neoplasm, which you can see here, some of these very high-grade cells almost immediately adjacent to areas of the keratinization. Now, whether that inflammatory response has any role in the progression of dedifferentiation is interesting and uncertain at this stage. But certainly in this particular case presents as an almost dominant feature to have all of this keratinizing material in the curettage sample. Now, needless to say, we did some further immunohistochemical evaluation on this case, and the findings from that were quite instructive, particularly here in the endometrial sample, where we had a dual pattern of staining, or a dimorphic pattern of staining with several of the markers. Specifically, we had quite distinct patterns of staining with PAX8, showing nice preservation in the well-differentiated or better differentiated component, and complete loss in the dedifferentiated or undifferentiated components. Additionally, the marking with cytokeratin was distinct in the two. So loss of PAX8 and cytokeratin were noted in this sample. So needless to say, in that first sample that we looked at from the vaginal tissue, the absence of staining for those markers, which we felt would be quite sensitive to the presence of neoplasia derived from the endometrium or from an ovarian tumor, were entirely misleading. And in fact, that was malignant tissue, as its morphology and H&E pattern would indicate, but did not stain in a typical expected fashion for an endometrioid carcinoma. Of note also was the presence of or absence of staining with the mismatch repair proteins MLH1 and PMS2, at least in the undifferentiated or dedifferentiated component of the tumor. In the well-differentiated component, however, which was a minor component in some of the sections, those markers were preserved and intact, as were the other mismatch repair proteins, PAX8, cytokeratin, hormone markers, and so forth. A pattern that can be confusing when you first encounter it, but is now recognized to be part of the dedifferentiation process. So as we've indicated in a prior video on dedifferentiated carcinoma arising in the ovary, this is a unique variant of endometrial adenocarcinoma, which presents as a high-grade undifferentiated carcinoma that is found in conjunction with a low-grade or lower-grade endometrioid carcinoma. However, there are certainly occasions when you have only the undifferentiated carcinoma and the low-grade tumor is no longer recognized, and those cases are diagnosed simply as undifferentiated carcinoma. The tumor has a high-grade appearance, areas of necrosis, rather adhesive, and typically the immunohistochemical markers show loss of a number of markers, including cytokeratin, PAX8, and often hormone markers like estrogen and progesterone receptor. Now, these tumors are usually p53 wild type and may occasionally have neuroendocrine marker expression and sometimes a loss of mismatch repair protein function, as we observed in our case. The unifying feature tends to be the loss of function in the SWI, SNF triad of markers, which include BRG1, INA1, and ARID1A. We don't typically test for all of those. It's not readily done, and they have certainly no significant prognostic difference at the present time, but it does help to confirm the diagnosis if you are uncertain about that. The other feature, of course, is that there is some variability in these molecularly. And in fact, a study done by Rob Soslow and others in the late 2016 publication, as you can see here, the genes that may be involved with this undifferentiated or dedifferentiated morphology can be somewhat variable and can include many of the other markers that we often think of as being characteristic of specific molecular subtypes, such as POL mutations, TP53 mutations, and so forth. It is evident, however, that the majority of these tumors now, as correctly classified, would include the ARID1A, BRG1, or INI1. But I thought this was interesting to see that there is some molecular heterogeneity associated with these tumors. And probably in the present setting, these other molecular markers would still carry some significance in terms of managing treatment and so forth. Well, our final diagnosis then in this case is dedifferentiated endometrioid carcinoma, which involves the endometrial cavity with areas of keratin granulomata, as well as involving the endocervix and vaginal tissues. Not having seen the primary ovarian tumor, we can't comment as to whether or not that also had areas of involvement and whether this represents metastasis from that or asynchronous development of ovarian and endometrioid neoplasia. Those are interesting and sometimes difficult questions, but certainly in terms of managing this patient's treatment, the dedifferentiated tumor should be the guiding factor, and involvement of lymph nodes and systemic treatment and so forth for those things should be followed appropriately. Well, thank you so much for joining me. I hope that you enjoyed this program. And if you did, please hit that like and subscribe and let me know your thoughts in the comments. I look forward to having you on a future program. And thank you again so much for sharing some time with me. And until next time, thanks so much for joining me.